Hello, I'm Kathy Schwartz. It is my privilege to present this video to you entitled Practical Clinical Guidance for the Screening of Hepatitis B virus infection. I am doing this on behalf of my two colleagues, Dr. Robert Gish of Stanford University and Dr. Jeannie Wang of the University of California, San Diego. These are our disclosures. The learning objectives of this module are as follows. Upon completion of this educational activity, participants should be able to recognize persons at risk for hepatitis B virus infection according to the recommendation from the Centers for Disease Control and Prevention, and identify hepatitis B virus infection using the tests recommended by the American Association for the Study of Liver Diseases. The program overview. These are the topic areas that I will be covering, starting with issues, challenges, and call to action on hepatitis B virus infection. This is a map of the world, as you can see, showing the prevalence of hepatitis B. There are at least 292 million hepatitis B surface antigen positive individuals in the world. You can see that the orange areas indicate areas of high prevalence, the pink intermediate, and the green low. There is a tremendous medical need for us to do better for individuals infected with hepatitis B. There are 257 million people in the world chronically infected with hepatitis B. This includes about 2 million in the United States and a total of 7 million in the Americas, 15 million in Europe, and 90 million in China. Unfortunately, about 1 million people die every year as a consequence of hepatitis B infection, despite the availability of safe and effective vaccines and antiviral treatments. This slide demonstrates the geographic diversity of hepatitis B infection. So in areas of low endemicity, such as North America and Western Europe, the age of infection is early adulthood. The primary mode of transmission is percutaneous, and also there is sexual transmission. Chronicity is rare. The risk of end-stage liver disease is low, and the risk of hepatitis B virus-associated hepatocellular carcinoma is low. In contrast, in areas of high endemicity, such as sub-Saharan Africa and the Far East, most individuals are infected via maternal-fetal transmission or in early childhood. The primary mode of transmission is perinatal with some horizontal transmission. Chronicity is likely. The risk of end-stage liver disease is high, as is the risk of liver cancer. This shows the estimated hepatitis B virus prevalence among foreign-born Americans assessed in 2009. It is important to notice that over 13% of the general population in the U.S. are foreign-born Americans. So the hepatitis B virus prevalence in all foreign-born Americans is 3.7%. It's about twice as high in Asian individuals, shown in the turquoise, and highest in those from Africa, 11.8%. Hepatitis B virus infection in the United States has been examined taking into account recent estimates of foreign-born individuals. So there are somewhere between almost 850,000 to 2.2 million infected individuals. The average chronic hepatitis B virus prevalence and rate among foreign-born persons living in the U.S. is 2 to 5.4%. We have studied hepatitis B infected children in the NIDDK-funded Hepatitis B Research Network and have reported on over 300 children with the infection. The majority have hepatitis B genotypes that reflect their international country of origin. The majority are Asian, half are adopted, almost all were infected via vertical transmission, and almost all have international origins, either adopted abroad or born to immigrants in the U.S. In 2010, the Institute of Medicine issued a status report on hepatitis B virus infection in the United States. The elements of the problem are that there are over 2 million people in the U.S. with chronic hepatitis B infection, 2,000 to 4,000 hepatitis B-related deaths every year. Unfortunately, the incidence of hepatitis B-related liver cancer is actually increasing, and over the next 10 years, greater than 150,000 deaths due to hepatitis B and hepatitis C are projected. There are two major underlying issues: lack of public awareness and lack of provider awareness. In analyzing these issues further, the Institute of Medicine pointed out that at-risk people are unsure that they are at risk or how to prevent becoming infected. They may not have access to preventive services. Many chronically infected people are unaware that they are infected. Many healthcare providers do not screen people for risk factors or know how to manage infected people. And finally, infected people often have inadequate access to testing, social support, and medical management services. This slide demonstrates the essence of hepatitis B virus disease progression. A staggering 2 people per minute will die from complications associated with hepatitis B. As I said earlier, there are greater than 250 million individuals in the world chronically infected. Unfortunately, only 8% are diagnosed, less than 1% receive treatment, and only 1 to 3% of those receiving treatment with currently available options actually achieve functional cure. 20 to 30% will develop cirrhosis and/or liver cancer and need surgery, chemotherapy, and perhaps liver transplant. 1 million people in the world die of hepatitis B, and that is 2 people a minute. This is a graphic demonstration of this problem. 90% of hepatitis B virus infected individuals remain undiagnosed, and 95% of treatment-eligible patients remain untreated. The graph depicts global hepatitis B cascade of care in 2016. The red bar shows the hepatitis B surface antigen positive individuals, greater than 250 million. The blue bar shows that about 94 million are treatment eligible, but only 28 million are diagnosed, as shown by the green bar, and a very small fraction of those, 4.7 million, actually receive treatment. This slide shows the costs of hepatitis B virus infection according to the various payors: commercial, Medicaid, and Medicare. The dark blue bars are the chronic hepatitis B infected patients compared to uninfected controls. And you can see across all types of insurance and all years of study, the costs of patients with chronic hepatitis B were significantly higher than those without the infection. The second major discussion is about hepatitis B screening. Hepatitis B screening practices among primary care physicians have been studied. There was a very interesting web-based survey of primary care providers in the U.S., a total of over 200 providers in New York, Los Angeles, San Francisco, Chicago, and Houston. although 95% indicated that they have screened patients for hepatitis B, only 20% of high-risk patients were ever screened. The box demonstrates the reasons for screening and the reasons for not screening. So the reasons for screening included elevated liver enzymes in a family history of hepatitis B virus infection and liver disease, and persons born outside the U.S. However, it's very informative that the reasons for not screening included that the practitioners did not consider the at-risk individuals to be at risk for hepatitis B. The individuals did not have symptoms of hepatitis or liver disease. 15% of respondents did not screen at-risk individuals because they had been vaccinated, and 13% did not screen because of lack of insurance. So what is hepatitis B screening, and why should it be done? Well, the goals of screening are to prevent transmission to close contacts and to reduce the risk of chronic liver disease through medical treatment and support. What is screening? This involves both risk factor screening and serologic testing. Who should be screened for hepatitis B according to the recommendations from the Center for Disease Control? The first are populations at increased risk for hepatitis B because of coming from areas of increased hepatitis B prevalence. These include persons born in regions with high or intermediate prevalence of hepatitis B virus infection. In other words, hepatitis B surface antigen prevalence of 2% or greater, and U.S.-born persons not vaccinated as infants whose parents were born in regions with high prevalence of hepatitis B virus infection, a hepatitis B surface antigen prevalence of greater than 8%. Secondly, populations for whom exposures should be managed. This includes all pregnant women, infants born to hepatitis B surface antigen positive women, injection drug users, men who have sex with men, household contacts, needle sharing, or sex contacts of persons known to be hepatitis B surface antigen positive, and the source of blood or body fluid exposure, such as needle stick or sexual assault. Thirdly, populations who should be screened in order to prevent nosocomial infection. These include donors of blood, plasma, organs, tissue, or semen, and hemodialysis patients. And finally, populations who would be at increased risk of medical consequences of hepatitis B infection, including persons who are HIV positive, persons with immunosuppressive therapy, and persons with elevated ALT or AST of unknown etiology. So what about screening persons with a history of vaccination? It's very important for practitioners to understand that hepatitis B surface antigen positive testing is recommended regardless of vaccination history for the following individuals: those born in geographic regions with a hepatitis B prevalence of greater than 2%, U.S.-born persons not vaccinated as infants whose parents were born in regions with high hepatitis B prevalence of greater than 8%, persons who receive hepatitis B vaccination as adolescents or adults after initiation of risk behaviors, including men who have sex with men and injection drug use. Who should be screened? Persons born in high hepatitis B surface antigen prevalence areas, which means equal to or greater than 2%. And as shown in the map of the world, this is most of the world, since most of the world is colored pink in this slide. These are the various hepatitis B screening tests. So of the hepatitis B antigens, the surface antigen positivity is to be interpreted as acute or chronic infection. Hepatitis B E antigen positivity should be interpreted as acute or chronic infection, infectivity, and wild-type infection. Of the hepatitis B antibodies, the core antibody indicates either present or past infection. The anti-E antibody indicates low infectivity or a mutant hepatitis B virus. The anti-surface antibody is a marker of immunity, but only if the anti-hepatitis B core antibody is negative. And the molecular assay for hepatitis B virus DNA is indicative of acute or chronic infection and infectivity. This slide depicts a typical interpretation of serologic test results for hepatitis B. If the person is negative for all the serologic markers, then the person is never infected and has no evidence of immunization. If the individual is surface and anti-core antibody positive, as well as IgM anti-core antibody, the individual is acutely infected. Chronic infection is diagnosed by S antigen positivity and total anti-core antibody positivity. Exposure is diagnosed by total anti-core antibody positivity. That individual is chronically infected, is not immune, and is at risk for reactivation. If the individual is anti-core antibody positive and anti-surface antibody positive, that still indicates exposure, chronic infection, no immunity, and the individual should be considered at risk for reactivation. If the individual has only anti-surface antibody positivity, then that individual should be considered immune due to hepatitis B vaccination. So we should be vaccinating all adults who are triple panel negative. This slide shows the recommended hepatitis B virus tests for various clinical scenarios. The recommended tests for all of these clinical scenarios include hepatitis B surface antigen, anti-core antibody, anti-surface antibody. The one exception are the infants born to hepatitis B surface antigen positive persons. And in addition to those recommended tests, the infant who completes the hepatitis B virus vaccine series should be tested again 1 to 2 months after the completion of the series. The recommended tests for the other individuals in these various clinical contexts, including people born to intermediate to high endemicity areas, those with injection drug use, men who have sex with men, immunocompromised patients, hemodialysis patients, pregnant women, contacts of hepatitis B surface antigen positive individuals, and HIV positive patients. In addition, persons with elevated ALT and AST of unknown etiology or with exposures to blood and body fluid exposures also should be screened with all hepatitis B serologic tests. The third topic area is the natural history of hepatitis B infection. On this slide, you see the typical serologic course of an individual acutely infected with hepatitis B who has recovered. First, the surface and E antigens become positive, and then the individual develops symptoms, typically fever and gastrointestinal symptoms. Then there is conversion of E antigen to E antibody at about the time that the surface antigen and the IgM anti-hepatitis B core antibody decline. And in the individual who recovers, the total anti-core antibody will be positive and the anti-surface antibody will be positive. In contrast, this slide depicts progression to chronic hepatitis B infection, typical serologic course. The E antigen is positive at least 6 months, and then finally, sometimes after years, there will be seroconversion to E antibody. However, the surface antigen remains positive, as does the total anti-core antibody, although the IgM anti-core antibody does decline after about 3 years. This slide shows a new 5-phase model of the natural history of chronic hepatitis B virus infection. Chronic infection can be high replicative and low inflammatory state. It can be immune clearance state, where you see the hepatitis B DNA decline. There can be reactivation with chronic hepatitis B E antigen negative chronic hepatitis. So the serum hepatitis B DNA and the ALT will be high again. If the individual attains immune control, the DNA and the ALT will decline, and the individual will be considered in the non-replicative state. And then finally, if there is surface antigen loss, but very low levels of DNA, this phase of hepatitis B infection is considered occult hepatitis B. What about counseling patients and family members? The recommended counseling actions for hepatitis B surface antigen positive patients are to have all sexual contacts vaccinated, to use barrier protection during sexual intercourse if the partner is not vaccinated or is naturally immune. Toothbrushes or razors should not be shared. Open cuts and scratches should be covered. Blood spills should be cleaned with detergent or bleach. The positive individual should not donate blood, organ, or sperm. And infants born to hepatitis B surface antigen positive mothers should be vaccinated within 12 hours of birth with the both hepatitis B immune globulin and the active vaccine. Hepatitis B surface antigen positive patient should be allowed to participate in all activities, including contact sports, and they can share food, utensils, or kiss each other. They should not be excluded from daycare or school or other group participations, and they should not be isolated from others. How does one evaluate hepatitis B virus infected patients initially? Well, of course, history and physical. Laboratory tests that should be done include a complete blood count with platelets, liver panel, and clotting studies, hepatitis B DNA and genotype, hepatitis B E antigen and anti-E antibody, and also antibody for hepatitis A, hepatitis C, hepatitis D in endemic areas and injection drug users, and the individual should be tested for HIV. In addition, the individuals should be tested with an ultrasound for liver cancer and screened with alpha-fetoprotein. And there should be a discussion about a liver biopsy, which of course is the best way to grade and stage disease, although it is not required, and there is increasing availability of non-invasive serum markers and/or tissue elastography to assess the stage of disease. Finally, let's discuss hepatitis B treatment considerations. The goals of therapy are to achieve sustained suppression of hepatitis B virus replication and remission of hepatic disease, and importantly, to prevent the development of cirrhosis, liver failure, and liver cancer. Unfortunately, hepatitis B virus, at least in the present time, is probably never cured, but rather controlled by limiting viral replication. The markers of treatment response include decreased serum hepatitis B DNA to low or undetectable levels, improved liver histology, decreased or normalized serum alanine aminotransferase, hepatitis B e antigen loss or seroconversion in e antigen negative patients, hepatitis B surface antigen loss or seroconversion, and this last category is considered a functional cure. Which adults with hepatitis B should be treated? Well, those with hepatitis B DNA greater than 2,000 international units per ml, ALT over 20 in women or over 30 in men, elevated biomarkers of hepatocellular carcinoma, any patient with cirrhosis with any hepatitis B DNA level, those of an older age who have active liver disease, and those who are considered at high risk for liver cancer, including those with a family history of cancer and with an actual diagnosis of hepatocellular carcinoma. There are several treatments for adults with hepatitis B virus infection. Monotherapy with entecavir or tenofovir is recommended based on the high barrier to resistance, and it should be noted that tenofovir comes in two forms: the original form, tenofovir, and tenofovir olefenamide or TAF. Pegylated interferon should only be considered as initial treatment for patients with mild to moderate chronic hepatitis B infection or selected patients with compensated cirrhosis. In other words, no portal hypertension. Adults with the following characteristics should be treated: an ALT over the upper limits of healthy, or fibrosis as measured by AST to platelet ratio or OPRI, or FIB-4 clinical scores, transient elastography or biopsy, and DNA over 2,000. Nucleoside or nucleotide analog treatment is indicated for these conditions. Individuals with cirrhosis and any hepatitis B DNA detectable should be treated with nucleoside or nucleotide analog. Entecavir or TAF is preferred over tenofovir when the adults are older than 60 years of age, have bone disease, or renal abnormalities. And TAF should be given over entecavir if the adult has been previously exposed to nucleoside analog. The management of nucleoside analog resistance is complicated and depends on whether the drug to which the patient is resistant is lamivudine, TAF, or tenofovir, or telbivudine, or whether there is multiple drug resistance. Which hepatitis B virus positive child should be treated? Well, it's an exciting time where clinical trials are ongoing and new information is emerging, and this decision does require specialty consultation. The currently available treatments, which are FDA approved for children with hepatitis B, include alpha interferon, lamivudine, which we seldom use because of a high resistance rate, adefovir, which also has a fairly high resistance rate, entecavir, which is more effective than either lamivudine or adefovir, and children 2 years of age or greater do have a 49 to 64% virologic suppression when treated with entecavir by week 96. Tenofovir is also approved for children 12 years of age and older. This would be 300 milligrams orally daily, which does result in a virologic response of 89% and ALT normalization in 74%. This is a summary of recommendations related to hepatitis B virus infection. Hepatitis B screening should be done in high-risk populations. The natural history of hepatitis B virus infection is that up to 25% of infected individuals may develop liver cancer or hepatocellular carcinoma. There should be counseling given to patients and family in order to prevent transmission by immunization and caution. The initial evaluation of hepatitis B virus infected patients includes virology, liver chemistry, and screening for hepatocellular carcinoma. And hepatitis B virus treatment considerations should be selected in conjunction with a hepatologist. Now that I've reviewed with you the key points regarding the importance of, care gaps related to, and the need to improve hepatitis B screening, you will now embark on a quality improvement project to improve your clinical practices related to hepatitis B screening and resulting management. Steps related to quality improvement that this module will address include self-evaluation and reporting, identification of target benchmarks and standards, and provision of additional training and education, both to provider and to patients. Next steps. This MOC activity is focused on hepatitis B screening and evaluating practitioner performance of recommendations related to hepatitis B screening. This includes completing a case report for each of 10 relevant patient cases over 3 data cycles, also completing an office report form for each cycle, and in between cycles completing a quality improvement plan. The current QI module in which you are participating involves the following activities. 1. Review of a PowerPoint slide presentation with accompanying video, which you've now completed. 2. Data collection and evaluation over 3 cycles, which are spaced out over time to allow time for improvement. And 3. Feedback and quality improvement. After each data collection, feedback will be provided to you for continued retargeting of goals for continuous quality improvement. Now what? Evaluation of practitioner performance of recommendations related to hepatitis B screening will occur via review of your completed report forms and QI plans. Specifically, you will complete a case report form for each of 10 relevant patient cases and an office report form over 3 data cycles. You should have already performed and submitted the initial data collection. You will be asked to develop a quality improvement plan to improve your practice of hepatitis B screening, to identify those who are hepatitis B infected for possible therapy, and, regardless of treatment or not, for ongoing monitoring. After each data collection, performance will be reviewed with you via a written report, and you will be asked to set new targets for practice improvement. Good luck!